full of time, and I know people will be joining.
Let's do it.
So welcome everyone to today's presentation of Community Grand Rounds. These rounds are hosted by the NARB Institute and Health Choice Arizona, Blue Cross Blue Shield of Arizona. We've been so fortunate since last summer when these rounds began to have a number of just phenomenal presenters, and today is no exception to that. I'll introduce Dr. Bob Wachter in just a second. Just lay out some very quick ground rules for today. Folks have come in on mute, but we do invite your questions through the Q&A as Dr. Wachter presents, and we will ask and synthesize questions during the presentation or after, whatever works best for Dr. Wachter before the end of the session. I'm Mark Carroll with Health Choice Arizona. I'm pleased to co-host these rounds with Mary Jo Gregory, President and CEO of the NARB Institute. Thanks, Mary Jo. And today we're joined by Dr. Stephanie Jackson of Honor Health, who will be able to help us think through just some questions for Bob at the end of his presentation. Dr. Jackson is the Senior VP, the Chief Quality and Clinical Value Officer for the Honor Health System. So thanks everyone for joining. And now we'll turn to Dr. Wachter. So Bob, I've had the pleasure of learning from you when you were the fellow in our fellowship program, although you had just finished that program when I began. So it's so nice to reconnect. Bob is the professor and chair of the Department of Medicine at the University of California, San Francisco. His department leads the nation in NIH grants and is generally ranked as one of the best in the United States. He's the author of many articles and 6 books and is known for coining the term hospitalist in 1996 and is often considered the father of the hospitalist field. Bob's also the past president of the Society of Hospitalist Medicine and the past chair of the American Board of Internal Medicine. As noted, he's written 6 books, 2 books on safety and quality, and his 2015 book, The Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age, was a New York Times bestseller. Dr. Wachter's received many awards in his career. Notably, in 2004, he received the John M. Eisenberg Award, the nation's top honor in patient safety, and has been recognized by Modern Healthcare and in numerous societies. He's an elected member of the National Academy of Medicine. In 2021, so we're in 2021, but in that year in particular, tweets on COVID-19 have been viewed by over 100 million times by at least 162,000 followers, and have served as a trusted source of information on the clinical, public health, and policy issues surrounding the pandemic. So it's my pleasure and privilege to welcome Bob to Community Grand Rounds. And Bob, I'll turn it over to you. Thank you.
Thank you, Mark. I wish I could be there, and hopefully we'll all be back in a different world by the end of this year. I'm actually fairly confident that we will. So I'm going to, let me share my screen, see if we can get that working. Hopefully you can see that. Let me see, head shakes. Yeah, there we go, perfect. Okay, so what Mark asked me to talk about today, there we go, is COVID and the transformation of the healthcare system and which changes will outlast the pandemic. Pandemics and other cataclysms often do lead to profound changes in systems, and some of them turn out to be good, some of them turn out to be long lasting. So I'm going to talk a little bit about what we've seen in the past year and which ones I think will have durable impacts on healthcare. I'll also talk about which ones may not, which I think is just as interesting. Let me start with what I call the Fouchy scale. This is to see how everybody's doing. This is 5 looks on Fauci's face in the past year. And if you saw him yesterday in the press conference, he definitely was a Fauci 1 compared to, I think it was during the bleach talk that he was Fauci 5. And I have to say, I'm now a Fauci 1.7, feeling pretty good about the plans that are being rolled out by the new administration. And feeling reasonable about the state of the pandemic, although it is quite horrible now, but things are beginning to turn around and get better. The vaccines are really very hopeful. Yes, the rollout's been bumpy, but it's beginning to accelerate. The real challenge, I think, is these new variants, and we'll have to see how that plays out. But that's kind of the speed bump that we have to worry about. Otherwise, I think I'm pretty optimistic about where we find ourselves. So what I'm going to talk about in the next 35, 40 minutes is how we've managed the pandemic and the problems it's exposed in our politics and society. I think it's worth framing that because it really does influence how we think about life afterwards. Talk a little bit about a few tech innovations that were accelerated by COVID, focus on telemedicine, which you've all thought about, but I want to take that a little further, and dashboards. A few other parts of the digital transformation landscape that if you'd asked me a year ago, I thought might have tipped, but I don't think have. I'm going to talk a little bit about where we are in the digital transformation of medicine, and I'm going to call it the post-electronic health record era. That does not mean you're going to ditch your electronic health record or that you wasted $200 million, but it does mean that we're going to be thinking about digital in a much more nuanced and diverse way going forward. And I'm going to talk about a couple of areas in which I believe everybody's saying the right things, but I do worry about follow through and whether we'll really stick with the plan. So that's where I'm going to go, and I'll try to go quickly enough that we have at least 10 minutes for chatting at the end. Let's talk just about pandemics and in general, and this I think captures the challenge. This is former Secretary of Health Mike Leavitt, who once said that everything we do before a pandemic will seem alarmist, everything we do after will seem inadequate. And certainly the past year, pretty much everything we have done has seemed inadequate. I think we could have done a lot of it much, much better, but even had we done it better, the toll would have been quite large. It's just the nature of a threat that comes along once every 100 years, and it's just not part of the human condition to prepare in the way that you would like to once you've seen the threat up close and personal. And clearly we were not prepared. This, I think, is, to me, one of the more upsetting things about the past year, and I don't obviously want to get too political here, but I think it is worth thinking hard, not so much about the past administration, but about what it says about America and our culture and our politics in terms of how we responded. This is Ed Yong, who's a writer for The Atlantic, who I think has been writing probably the best stuff on COVID and its meaning since this started. And this is, recognize the date, March 25th, very, very early in the pandemic. And Ed said, aspects of America's identity may need rethinking after COVID. Many of the country's values have seemed to work against it during the pandemic. Its individualism, exceptionalism, and tendency to equate doing whatever you want with an act of resistance meant that when it came time to save lives and stay indoors, and I'd probably add, and wear masks, some people flocked to bars and clubs and didn't wear masks. Having internalized years of anti-terrorism messaging after 9/11, Americans resolved to not live their lives in fear, but SARS-CoV-2 has no interest in their terror, only in their cells. I think it's a pretty profound way of thinking about it, that they're really, it's easy to sort of point to the administration that happens to be in charge at the time, but I think it really demonstrated, our response demonstrated this sort of tension of the American kind of libertarian streak and how poorly that works in a pandemic. You can argue whether it works well in other walks of life, but clearly was not built to be to serve us very well in a pandemic. New administration, and things feel like they've changed quite a bit. If you want something amusing, just watch yesterday's press conference with Fauci and see kind of how he looked like a kid in a candy store. He was having such a good time. What will the next year look like in COVID? Here is my projection. I think we're going to see a coherent and much more aggressive plan from Washington. We've already seen evidence of that in the last couple of days with competently led federal agencies relatively free of political interference, with efforts to promote and departisanize non-pharma interventions, particularly masks and testing. Whether businesses and schools are able to open depend very much on the regional specifics in terms of prevalence as well as in terms of politics. Surges, which have begun to peak and are starting to come down now, but won't be completely tamped down until we reach population levels of immunity of about 40%. That doesn't mean that that's when we reach herd immunity. It's not, but it's when you start seeing enough immunity in the population to really bend the curve in a major way. And that doesn't have to be all vaccination. It can be a combination of vaccination plus prior infection, assuming prior infection creates long enough lasting immunity to work. So we probably reach those levels in April-ish. Now, the problem is these new, more infectious variants may challenge this timeline and this threshold, and I think that's the great unknown at this point. In addition, I think the therapeutics will continue to improve and will lower the mortality rate. although people's comfort with that may be tempered by the possibility that, that we sort of treated COVID in the beginning as you either die or you get better. And we now know some people don't die, but don't get completely better. And there's some long-term health threats that we just don't understand in terms of ongoing cardiac damage, things like that. So, but I think it is fair to say that we've already, the mortality rate for a case of COVID is less than half of what it was in the beginning, because we've gotten better at treating it, and probably will continue to improve. Vaccine distribution will remain contentious, particularly around who goes in which place in the line. And the issue that's going to become the most contentious issue later will be this issue of immunity passports, whether you need to show proof of vaccination or proof of immunity to get into a theater, get into a restaurant, get in an airplane. I think that's almost, that's highly, highly likely, and it will be very, very contentious. When will we get, quote, back to normal? Hard to predict, but I'm guessing probably in the fall, once we get to 60 or 65% of the population immunized plus prior infections. When you get to that 2/3 of the population immune one way or the other, I think you're going to see life returning close to normal. Whether people still wear masks in crowds, maybe some. Whether everything is open, hard to know, but it's going to be a lot closer to normal than it is now. So let's turn now to technology and sort of the role of COVID in the acceleration of innovations and kind of digital transformation. And let me sort of start with my view of the end game. My view of the end game here is there is no question that the American healthcare system will be transformed by technology, because every other industry has been. Think about the way you watch a movie, think about the way you travel or buy books or any other goods. All of them have been utterly transformed by technology. Healthcare is probably the last in. And so the end game clearly is an environment where people are getting more of their care at home, using sensors, using artificial intelligence, using apps, more predictive analytics. There's no question that will be the end game. Question is that 5 years from now or 20 years from now? And that's kind of what I want to address, and whether COVID changed that curve and accelerated it. And the answer to me is yes in certain ways, no in others. So the most obvious one, of course, is telemedicine or video visits, without question. This is UCSF's curve. You probably have something that looks just like this, where we were doing about 2% of our visits through telemedicine, bumped to 55% in a month. By the month after, it was 70%. And a lot of places it's come down to 20. For us, it's still at about 50, even now, a year into it. So a profound change in the adoption curve of a technology that was ready for prime time, but was not being adopted very quickly. And what were the enablers? Biggest one was fear. Patients didn't want to come in, clinicians didn't want to come in, so that accelerated the adoption, but also some changes that were made at the federal and state levels, relaxation of some of the regulatory barriers, payment parity, and the future of telemedicine will be determined by what happens with these payment and regulatory changes. My strong suspicion is that the barriers will remain quite low. I don't think, now that the genie's out of the bottle, I think it would be really hard to believe that either federal or state regulators would say, we want to make it harder to do televisits, or that the payers will make it much, much harder to get paid the same for a televisit as an in-person visit. I could be wrong on that, but my reading of the tea leaves is now that everybody's experienced it, there are enough clinicians that like it and enough patients that like it, that we won't be able to go back to where we were before. So I think this is a real tipping point. Here's to me the fundamental, and it's sort of easy, okay, fine. The fundamental question really is it just a visit replacement? Is it, okay, that's a pretty big deal. We've changed the nature of a visit, and that's fine. It's more convenient for patients. Maybe it's even better for providers in some circumstances. It also potentially opens up new non-geographically determined care options, which I think should be good for patients. If you have a rural patient and they can see the doctor in Phoenix and do it through a televisit without driving 3 hours, that probably is a good thing. Obviously, it creates new opportunities, but also competitive threats for health systems. I was just on a conference with the person who's leading Mayo's efforts to develop a national platform that does telemedicine plus digital care in other ways. And in the old days, if Mayo says we want a presence in Arizona, they had to build or buy hospitals and clinics in Scottsdale. But in a virtual world, they maybe don't. And they, Amazon happens to live in Seattle, but what difference does it make? They are everywhere. And so you're going to start seeing the emergence of national brands in a way that could not have happened when care had to be geographically determined and you needed a building. So that's going to be a very interesting sort of political shift and a difference in the way we think about how care is organized. But to me, the real game changer is telemedicine just a step along a path toward more virtual care? That's the real game changer. And I think the reason that telemedicine may accelerate that is, in the old days, if you were seeing a patient in your office and to get their blood pressure, they had to come in. To get their weight, they had to come in. To check their glucose, they got it when you came in the office, and your MA did that. If they're not coming in anymore, you now have to get their blood pressure from the digital cuff they're using at home, or stepping on their digital scale, or using their digital glucometer. And so we're going to become increasingly dependent on these digital data streams that probably are better in a way, because if you think about it, why make a decision based on a blood pressure you check once every 3 months at a time that they're tired because they just parked in the parking lot and walked to your office, or there's white coat hypertension because they're scared of seeing the doctor. It probably makes much more sense to base it on their blood pressure they've been checking every day at home on a digital cuff. But the billion, and I'd say maybe $1 trillion question is, okay, that's great. How are we going to manage these new data flows? And that's the stuff we have to really think hard about, and I worry a lot about. So here's what this looks like. Patient has their Apple Watch, or you name whatever the product is, it's measuring their heart rate or their SAT. And periodically I'll hear people say, oh, it's going to be terrific because all that data is going to go to the primary care doctor, who is going to say, this is great. I can now have all of this extra data on all of my 1,800 patients. And I can tell you, I have about 300 primary care doctors that work in my department. And if I told them that was happening now, they would all quit by 5 o'clock this afternoon. That is not doable. And you know that. It can't possibly work. If you're taking all of this new digital data from the patient's body and from their home and from sensors and surveys and flow it into the healthcare system, the existing healthcare system, the system will break within a day. Just can't work. So what is this going to look like? I think it's going to look like this. And John Halamka from Mayo calls these people care traffic controllers. And it's that there's some new middleware in the system that is monitoring the data flows, and through some combination of artificial intelligence and then triage, and this has to go to this kind of person and this has to go to that kind of person, we manage it in new ways that are not everything gets mainlined to the doctor. So here are 3 ways it might look. Patient 112, sugar is high. Again, the algorithm bumped the insulin, but let's get a coach involved. Or patient 42 has an irregular heart rate and a shorter breath. Let's do a televisit. Or maybe a few more years out where everybody's got the Internet of Things and everything in the house is wired. Patient 13's weight is up and oxygen saturation is worse. I'll lock the salt shaker and the refrigerator. That's probably a little bit out there, but you can imagine a world where not only is it giving you advice, but it's triaging it to the right person. Maybe it is doing something, an effector arm in your house, who knows? But there's got to be a layer that's built that's like this. And as I say, Mayo's working on it. We're working on a little, we're not at that level yet, and there are lots of companies that are entering this space recognizing that that's a profound need. So I kind of leave you with that in terms of telemedicine. Telemedicine is big, it's important, but to me, the biggest question is, does it pave the way for a much broader and much more robust version of digital health, with much more care being driven by patients who are at home with new data flowing from their daily activities? And then the question is how we manage that. And that's a big, knotty question. I'd say a second thing that tipped, and it kind of surprised me, I wasn't looking out for it, but in retrospect, it's obvious, is that we're now taking all that data and beginning to do something we should have been doing all along, which is delivering usable real-time information in visually attractive and actionable form to both leaders and to clinicians. And one way of thinking about this is a dashboard. It sounds like a duh, of course, but most healthcare systems, it's part of what has upset clinicians so much about their electronic health record. They feel like they're spending all of their time putting information in, and they get so little useful intelligence out of it. And whether it's decision support or just dashboards, just information presented them in an attractive way and usable way. And you're in the weeds when you say to them, go to this website, there's all the data, and there's like some massive Excel spreadsheet. That's not helpful. They will not use it. It's might as well not do that. So an important developmental stage in our digital journey has been taking all this data that's now sloshing around through our digital systems and delivering it back to people that need it in a way that is actually useful and usable. And I think COVID has accelerated that in a big way. This is UCSF's COVID dashboard. I go on it every day, and it's updated constantly. And this is a couple of days ago where our numbers are down a little bit, luckily. And in a second, I look and I see, look in the upper right, and I see how many patients we have in the hospital and how many patients in the unit and how many patients on ventilators. I look at the lower left and I see our test positivity rate. We're testing everybody, so it's actually divided into patients with symptoms that might be COVID, and then other patients who came in for a cardiac cath and got tested. That's my poor man's way of guessing what the chances that the person next to me in a supermarket in San Francisco has COVID. Sort of an asymptomatic carrier, asymptomatic person in San Francisco. And then other data here, all useful, beautifully presented, one stop. I look at it, I know what I need to know. I can't think of many examples like this in healthcare pre-COVID, and I can think of a lot of them that have come out since COVID. So I think it has been a golden age for dashboards and the more general sort of thinking, how do we use all of this data that we're now collecting digitally to give it back to people that need it in ways that actually are useful? I think it's a really important question. I think that has been something that COVID accelerated. Here is our vaccine dashboard. This is a couple of days ago. We're now up to about 22,000 people vaccinated at UCSF. But again, I go on this every day to see how we're doing. It updates itself every day, done in a way that is easy to follow, well laid out. So nice things, and you're probably doing some of the same in your system. This is a 91 DIVOC, which is COVID spelled backwards. I go on it every day too. Everybody has sort of the go-to visualization mapping dashboard for COVID. This is mine, and it takes 2 seconds for me to look at the trend line of cases in the regions of the United States, shown here as of maybe 3 or 4 days ago. So these kinds of dashboards that do projections or do data visualizations about the state of the pandemic. Again, not rocket science in a way, all capabilities that we've had for a while, but I think what COVID has accelerated is the recognition that once you're collecting all this digital data, your ability to give it back to people that need it, doctors, nurses, patients, families, healthcare leaders, system leaders, is great. We just haven't been doing it. So I think this has really hit its tipping point. And here's another one. This sort of gets into the world of decision support. This is something called microcovid.org. It was developed by 6 self-professed nerdy roommates in San Francisco who were just struck that they were wondering themselves, like, should I do this or that? And they built a site that knows where you are. So you say, I'm in San Francisco, or you say you're in Phoenix, and it knows the state of the pandemic. You don't have to put that in. It knows your prevalence rates. You tell it what you're thinking about doing. Here, it's a one-time interaction with 4 people being about 6 feet apart. You're going to do it for 15 minutes. All the people live alone and they only visit grocery stores. You're going to do it inside, and everybody's going to be wearing, let's say, a surgical mask. And you put that in and you click OK, and it gives you your risk for that activity in what they call micro-COVIDs, which is chances of catching COVID per million interactions. And so you just try and decide, do I fly? Do I go to the grocery store? Do I, all this sort of things. It's pretty neat. And again, I don't want to highlight it per se. I think it's a nice thing, but it just shows the power of digital to take this data and give it to you in a form that's actionable and answers a question that I think we're all asking 100 times a day. Stuff that there was very little of this in healthcare until recently. I think COVID really is accelerating. Those are the 2 main digital things that I think are accelerated. Telemedicine, and by virtue of that, sort of digital transformation more generally, and sensors and all that, and dashboards. Here are 3 other areas that might have been accelerated, but I don't think were, personally. You might disagree, but this is my take. AI, data sharing, and interoperability. Here's the world of AI. This is from a year ago. It's probably bigger than that now. These are all the startups in the AI space for basically every use case you can think of. But here's my bottom line. While one might have anticipated that the pandemic would be a moment for AI to shine, I can't identify a truly game-changing AI application. So in terms of where AI is in its hype cycle, I think it's still more hype than real. I think some of these companies will be winners and produce products that really are useful. Whether they actually manage to get bought and make money, I'm not sure. But I don't think the pandemic was the shining moment for these companies just yet. Nor was it the shining moment for using your consumer-facing digital tool to, in this case, the use case is contact tracing. And you probably know I think it was April, Google and Apple announced they were working together, which was remarkable just by itself, to produce an app on your phone that would allow you to be signaled if you happen to have been close to someone who turns out to have tested positive. So essentially digital contact tracing, pretty neat idea, but it requires that everybody opt in, not just you, but the person who you came in contact with. And it's not really done very much. And part of the problem is that not enough people have opted in. And part of the problem is in order to make it work, it had to link to state public health department databases. And what the folks at Google tell me is that when they got in there, they were just amazed by how woefully behind state public health digital systems were, which shouldn't be that surprising given how underfunded state health departments are. But the other reason was a lot of people did not want to share their data with Google and Apple. And of course, you know why. This is trust in tech giants, a survey done a year ago. And you see that 22% of people trust their data going to Apple, 13% of people trust it going to Google. So people have a lot of reluctance, despite all of the reassurances they got from the companies that the data is not going to be used other ways and not going to be sold. People have a lot of trust problems with tech giants, which gets in the way of these kinds of tools. So I don't think these tools have tipped either. And just making the point I just made, I think the lack of trust has gotten in the way of taking advantage of what could have been really an important adjunct to the way we think about contact tracing in this example. Finally, interoperability and sort of the overarching nature of how data systems sort of fit together, and you know, one of the things this pandemic clearly exposed is the lack of a unified, uniform data system in the United States. Here was a request that came out of the COVID task force the vice president was running. This was in late March. Basically said every hospital should put all of its data about its testing, how many people are tested, how many positives. They should put it on a spreadsheet and they should fax it into the White House. That was in 2020. That was our system, to record it manually, then put it on a spreadsheet and fax it in. Not what you would call a modern digitally connected system. And it might have been an opportunity to improve interoperability, but I think we still find ourselves faxing spreadsheets in too many cases. It brings up a more broader point that I think is really kind of one of the key points in the digital transformation of healthcare, which is that health IT needs its golden spike, and we still have not quite laid it. So this is the Transcontinental Railroad, and we of course needed something to connect East and West Coast. Haven't really connected the two types of digital data in healthcare just yet. Increasingly, the data is being collected in the form of consumer-facing digital tools, whether it's your smartwatch or your Alexa or your iPhone, or you went off and got gene tested, all being collected in digital form and data systems. But those, they don't connect with each other, certainly, and they certainly, in most cases, do not connect with the enterprise systems like Epic and Cerner. So you have a lot of data lakes. And the experience of most other industries, if you think about your GPS system and how it works, or you know or how Netflix works, or the banking system works, one of the things that really accelerates it is when it's all connected. I can take my B of A card and put it into a Citibank machine and get money out. And that's because it's a completely interoperable system, which healthcare clearly is not. Now, we have Epic at UCSF, and Epic is pretty interoperable within Epic. They've seen it as a feature they want to promote, that I can get data on my patients that they've been seen at another hospital that has Epic. But God forbid they've been seen at a hospital that has Cerner, no way. And getting data out of something that was collected on their phone or in a genomic testing site, very, very hard to do. So we really have to lay the golden spike in healthcare. I don't think we've made much progress on that in the last year. It's going to be an important part of the new administration as they think about digital transformation. So let me talk about the post-EHR era, which I think is the era we're entering now. I've said a lot of stupid things to people I've advised over the years. I may have said something to Mark way back when, but this is the stupidest thing I've ever said. This is Russ Kusina, who is our chief digital officer at UCSF. I hired him about 12 years ago for the job, maybe 13 or 14 years ago for the job. And I said, you're going to have a big, important, interesting job for the next bunch of years, because I know we're about to implement our big electronic health record. And I'm sure it's going to take a few years to do that. And then there's going to be some upgrades and all that. And then I really did ask him, what will you do after we're done implementing that? I thought, like, okay, that's it. You're done. We're done with digital. I don't know what you're going to do for a living. That, of course, was asinine. And we're now entering the stage where the penetrance of electronic health records in hospitals and doctors' offices in the United States is closing in on 100%. It's well over 95%. So we have put electronic health records in most of the American healthcare system. Where we find ourselves now is in an era where there's a whole lot of other digital stuff happening, and it's happening independent of, but ultimately will need to be connected to the electronic health records. And that will allow a level of acceleration, of transformation and innovation that I think will be really exciting, but it's kind of bumpy path. And here you see the investments in new digital health startups. I live in the Bay Area, so I see a lot of it is happening around me. That's growing quickly. And all of the digital giants are jumping into this. Many of them tried to be in it 10 or 15 years ago and failed because Google tried to build Google Health 15 years ago and got out of it after a couple of years, because they said it's just too hard. The data is not in a form that we can do our googly thing. But that's changed now. So you have Watson trying with IBM, mostly failing, but trying in a big way. Google has hired an all-star team of healthcare leaders. This is David Feinberg, former CEO of Geisinger, former FDA Commissioner Rob Califf, sort of every healthcare leader I can think of who was looking for a position in an innovative world has joined Google these days. Microsoft is doing some of the same. Apple obviously is doing their watches and other things. And the big play here was something called Haven, which was Amazon, JP Morgan, and Berkshire Hathaway coming together to try to transform healthcare. They hired Atul Gawande, brilliant Harvard surgeon, author, and they just announced last month, I believe, that they're taking it down. So healthcare must be pretty hard to transform because all these companies are coming in with huge investments. It's not an easy lift, but it is an important thing to say that every digital company in the world is trying to make a play in healthcare. There's a lot of funding. There's a ton of startups. And I think there will be winners ultimately. There will be companies that really do figure this out. So why are we at this stage? Partly because if you think about who won the electronic health record derby, it could have been Google, it could have been GE, they were all in it, IBM was in it, they all weren't the winners, because it turned out you needed to be a one-trick pony. You needed to be a company built to build an electronic health record. It was such a hard thing to do that if you were kind of doing it as a sideshow, it was just too hard. So the winners were Epic and Cerner and a few other companies focusing on more ambulatory and maybe specific use cases. But and they were good at what you needed from your electronic health record, collecting data and moving it around. And they were ready to go when healthcare went digital 10 years ago. Think about what you'd want from your digital tools today. The companies weren't built to do any of these things. Consumer-facing tools, really wonderful user interfaces, learning from data, that could be AI, machine learning, communication tools, visualization, enabling telemedicine, taking data from sensors, everything. None of these companies were built to do any of this stuff. They're trying to figure it out. They're trying to hire some people, but it wasn't their job to do that. But now we're entering an era where the value pressure to deliver care that's better and safer and more accessible and more equitable and more based in people's lives and homes rather than hospitals and clinics, and do it at a lower cost. Population health needs, interoperability, which is growing, cloud computing, artificial intelligence, digital companies entering and getting better at this. And I think the obvious limitations on what EHRs can offer. So I don't think your electronic health record is going to go away. If you're an information officer and you're just saying like I just spent all this money on my EHR, or you're a CEO, like what's going to happen? What's going to happen is you're going to have your EHR, but it's going to be increasingly at the center of a much more complex and nuanced ecosystem where it's not the only digital tool that you have. And that raises some really interesting and profound organizational questions and challenges. That's how we're dealing with it at UCSF. We have our group led by Russ Casino, I just showed you before, that we call our health informatics group. They are the people that run and improve and upgrade the electronic health record. That is their thing. We have a whole nother group called the Center for Digital Health Innovation That's another group of digital experts, but their role is somewhat different. Their role is to take a big, knotty problem that we're going to be working on for the next several years and ask, how are we going to address that? What are the digital tools? What are the changes in workflow, workforce that we need to address that problem? And the reason those are two separate groups is the group doing our EPIC work just does not have the bandwidth and to some extent the expertise to do that. And on the other hand, this group doing this sort of innovation, future thinking, big picture, solving a tough problem can't be also running the computer system day to day. They're just two very different groups of work, but ultimately these have to weave together and the groups work very closely together. I think it's working pretty well. This is the biggest use case we're working on now that we call the digital patient experience, which is everything from how do patients schedule a visit to how do we do televisits with them, to how do we monitor them, to how do we remind them, to what kind of decision support do we give them and their families. It's the CDHI group is working on that problem over the next 3 years, trying to figure out what parts of this are tools that EPIC has that we could use. What parts of this do we need to buy from a third-party vendor? What parts of this do we need to build? And it's something, I think it's going to be increasingly what digital transformation in big health systems looks like. And sometimes this work is called fusion, where you basically are having to weave these two things together, the sort of day-to-day digital work you're doing, and then the more blue sky, longer time horizon, really complicated, that has to be built somewhere else and then ultimately bolt into the system so that it's an integrated experience. Let me end with a couple of observations about two really important areas that I worry about whether they will have staying power in the healthcare landscape in a post-COVID world. One is public health and preparedness, and the other is our approach to healthcare disparities. And I'm taken by this comment by one of the great investors of all time, Warren Buffett, who said, I have 3 boxes on my desk: my inbox, my outbox, and my too hard box. And I'm going to make a prediction that public health preparedness and the public health system in general and healthcare disparities, right now, everybody's saying all the right things, and I hope that that's true, but I worry that they will ultimately be filed, at least to some extent, in the too hard box. And let me tell you why. People are talking about health disparities like it's a new thing in COVID, like it never existed before. And of course, anybody who follows healthcare knows that that's ridiculous. It's long been said that your zip code is more determinant of your ultimate health and outcomes than your genetic code. And I think it's shown vividly here, and I'm sure you have examples in Arizona as well, of life expectancy in different zip codes in New Orleans. And you see here in areas that are just a few miles apart, if you are living there, your life expectancy is 80. And if you're living in another part of town, your life expectancy is 55. So yes, COVID has exposed disparities in case rates and in death rates. They're very real, they're very upsetting, but it's not new. We've known this in cancer, we've known this in heart disease, we've known this in hypertension control, diabetes control. Everywhere you look, prenatal care, everywhere you look, there are disparities. So I'm glad that COVID has shined a light on it, and maybe it will get more real attention and action than we've seen before. But I'm a little skeptical of that, and I'll tell you why in a sec. I sort of feel somewhat the same way about preparedness, that it's easy right now to say, my God, look what trauma we've all gone through. We have to prepare for the next pandemic. And I think you'll see, particularly under this new administration, a real effort to do that, and a real game plan, a button that you push when it looks like there's another COVID coming around the bend that sort of begins to move the system in the right way. So some of it's clearly going to happen, but the question is, will we really, really prepare? And so I like this quote. You may have heard this: the most promising way to deal with a possible recurrence is to sum it up in a single word: preparedness. And now is the time to prepare. I don't know whether you think that was Dr. Fauci who said that or the new president. It turns out it was the Surgeon General in October 1918 talking about the impact of the great influenza pandemic. So it's a recurrent theme after cataclysms that people's interest in them always has a degradation curve that begins to kick in the minute the thing is over. And so those are my concerns, and my concerns that this may end up, these two imperatives may end up at least partly filed in the too hard box, partly because of the politics. So here's my prediction, and I don't say this with joy, and nor do I hope that this happens. I hope the opposite happens, but here's what I worry: that everyone will profess to be committed to adequately resourcing public health and preparedness, but beyond having an off-the-shelf plan for the next pandemic, the support will weaken once the pandemic is over. Why? Partly because there's no powerful constituency for it, and partly because they're competing against areas where there are powerful constituencies. One of them is us. So, and some of you may work in the public health system and you're not in the same position, but I can tell you, working in a very large, multi-billion-dollar academic health system, we can say, you know, we really want public health to be adequately resourced, but how are they going to pay for it? They're probably going to cut the amount of money they give us. Who's going to be out there lobbying for that not to happen? It's probably going to be us, saying we need that money because we're doing God's work here. We're training medical students. We're doing research. We're doing all this important stuff. We need to be able to hire and keep our people and build a new building and put in this new technology. So there are very powerful constituencies for the status quo. And really the problem is prevention does not tend to have a powerful constituency. How about disparities and health equity? Well, I think everyone will profess to be shocked by the disparities, and I say shocked in the Casablanca kind of way, illustrated by COVID-19, although, as I said, they've been well appreciated for decades. I think you'll hear lots of people talking about it, and some of it will be real, but some of it then I think will recede. And because I think it's actually a harder problem even than public health, because you can imagine in public health, all right, the money is staying in the healthcare system, and we're just redistributing how much of it goes to the acute care part of the healthcare system versus how much of it goes to a different part of the healthcare system. But sometimes those systems are linked. And so that's one thing. But in terms of disparities, yeah, there's a healthcare piece of it, clearly. But if you look at what causes disparities, most of it is outside of healthcare. And if you were going to say, we want to fix disparities, you would be focusing on social and socioeconomic determinants of healthcare. Most of that is taking money away from the healthcare system and putting it somewhere else. So you would invest in housing and in jobs and the justice system and education. And you would also engage in significant income redistribution. And I think it'd probably be the understatement of the year to say all of these things are politically challenging. All of these have very powerful constituencies that will fight them. So while I hope our actions live up to our words, I'm a little skeptical that they will, and we will see how it goes. So let me end with this, and then hopefully it looks like we have 10 or 12 minutes for conversation. This is a very senior clinical cardiologist at UCSF. His name is Mel Chetland. He's a wonderful guy. And I was at a meeting several years back where we were talking about all of the changes in healthcare, and that was, you know, digital and telemedicine and regulatory changes and payment changes, and really the healthcare was being profoundly transformed. And I could see the senior members of my faculty getting more and more despondent, and they were going online to check their 401k to see when they could retire. And Mel got up at the end of the meeting, and I would have expected that would be, you know, his MO. He lived through the golden age of healthcare. And he said something I'll never forget. He said, you know, this could be worse. And I was very surprised by that. But then he went on and he said, I could be younger. And I found that amusing. And also I tell it to you because I actually think it's wrong. I think there's a lot of bumpiness ahead of us, but I think the transformation that we're going to see in terms of telemedicine, virtual care, artificial intelligence ultimately becoming real, the use of dashboards, and more broadly, the use of all of this data we're collecting to be given to us and our patients in ways that actually do improve health and healthcare. I think it's going to be very real. It's been bumpy so far, but I think that over the next several years, we'll start seeing changes that really do make healthcare better, safer, more equitable, and ultimately, as we need to do, less expensive. So I'm actually quite optimistic. I'm optimistic that we're going to see the end of COVID by the end of this year, and optimistic that some of the changes that COVID has accelerated will be real and will actually change healthcare for the better. So with that, let me stop and look forward to chatting with you.
Bob, thanks so much. I share that optimism of yours. It's actually really heartening to hear you bookend this with optimism, because despite the challenges that we're in, when we have engaged, committed folks like you and the folks that are joining us today as participants and the panelists, I'll ask now to come to present some questions to you. I think there is a lot of opportunity for optimism. Before I turn and ask Steph Jackson to offer a question, I just want to welcome Dr. Teresa Cullen from Pima County Public Health Director. Terry's joined us. Terry was a little, had some other things going on in the public health space that she had to join a little bit late. So thanks, Terry. So Steph, do you want to ask the first question?
Sure. Bob, you are also known to be a very, very influential person in patient safety movement nationally. And I'm curious what you think the long-term impact of COVID pandemic will be on the patient safety movement. Have we stepped back, 2 years, 5 years, 10 years with this current crisis, and where do you see it going forward?
Yeah, thank you, Steph. I don't think it has changed the trajectory of the patient safety movement in a major way other than telemedicine. I think telemedicine will be accelerated by it, and it raises some new patient safety issues, also some new opportunities, but some new issues in terms of our ability to monitor our patients, the fact that it's harder to do a physical exam, those sort of things I think will raise new questions. My overarching fear about the patient safety movement is when it started, you remember, with the IOM report in 2000 really launched the modern patient safety movement. There was several years where it was the main thing. Let's figure out I can't believe that we're killing this many people because of medical mistakes. Let's aggressively attack that. And within a couple of years, there was the quality movement. And then a few years later, there was questions of patient satisfaction and patient experience. And then there were provider experience. And then for the last several years, we've added health equity and access. And now, of course, overlaying all of it is cost and the need for efficiency and to remove waste. All of those are right. All of those are important. But I think that they have taken patient safety and sort of squeezed it into a smaller part of the agenda because there's so many other competing agendas. So the most hopeful thing, I think, in the patient safety field is so many errors happen because of a poor information flow or inadequate decision support. And I actually do believe that ultimately our digital systems will help us provide care that's better and safer. They have done that a little bit so far. When you think about medication errors, it's safer than it was before because it's better if it's digital than on paper. But we've not really taken full advantage of the digital capabilities to help us with diagnostic errors, to provide decision support, to allow clinicians to more readily give them the correct care, the evidence-based care, to kind of follow patients through the continuum and help with transitions. And I think, these digital systems that we're going to develop now, I think will ultimately help, but I do worry about patient safety because I just think it's competing now for attention and for resources against so many other things, quite appropriately, but it just means there's less bandwidth for it than we had 20 years ago.
Yeah, thank you. There was a question that came in, and Mary Jo, I'm going to ask you if you'd like to ask Dr. Wachter a question, because I think it would be similar. There was a question around healthcare worker well-being and just the mental and total well-being of healthcare workers. But Mary Jo, would you like to ask a question?
I was just going to go down that line, Mark, and ask you, Bob, as you look at this from the behavioral health point of view, both on the healthcare worker well-being as well as the importance of behavioral health not being on the margins, but really being in center as we go forward. Any comments on that you think would be helpful?
Well, I think we were already talking in 2019, we were talking about clinician burnout and the profound stresses on clinicians, in part because of these digital systems have opened up the gate to essentially 24/7 access of patients to clinicians, which of course is good, but we haven't created a business model for that. So clinicians felt overwhelmed by that. They also, I think, feel overwhelmed by the socioeconomic determinants of health that they often feel powerless to address. So, and then COVID on top of it has just been a profoundly difficult year, and ultimately, a year and a half, 2 years that have taxed the resiliency of everybody. So what happens coming out of it? I am hoping that that what I said to you is not true, that there's more help in the public health system to address some of the social determinants. I'm not convinced that clinicians can have a real role in terms of dealing with the education system or patients who are marginally housed. I am convinced that clinicians be able to collaborate with other people and institutions that do that. And the absence of that has been a profound problem. So I'm hoping that there is more resources for that. I'm also hoping that the next generation of digital systems do recognize the fact that just the burdens that they put on clinicians made the jobs undoable. And we're going to start seeing that soon. So, one example of that is digital scribes. Part of what's so unsettling about your computer system is you feel like you're spending all that time feeding information into it. And many places have hired scribes, but they're very expensive. But you can see there are a lot of companies working on this. And I think within a few years, there will be some Alexa-like device sitting in the office or on the televisit, hearing the conversation and creating your note for you. Now that can't just be transcription because that's worthless. It can be, all right, here's the conversation and here's what the doctor would have typed. I will go ahead and do at least a first draft of that. So I think you're going to start seeing digital solutions for some of the problems that digital created that I think have augmented burnout. And ultimately AI will help there as well by sort of figuring out what the patient needs and providing some level of help and decision support so it doesn't all go to the doctor. But it's a long journey to get there. And there are a lot of companies working on it. And I'm pretty hopeful that we're going to start seeing some products roll out that are going to make this a little bit better. And I guess I'd also add that one of the things that telemedicine has proven to be incredibly good at is telemedicine or even phone call behavioral health care. So, I think to me unambiguously, the move toward digital, toward telehealth has enabled a level of access for behavioral health that simply did not exist before. And that's really healthy, whether it's the digital, whether the behavioral challenges are on the part of clinicians or our patients. I think it's just opened up the system to more options for anybody who needs behavioral health. And the fact that it's become less stigmatized, I think all of that is a very positive note.
Great. Yeah, thank you. Appreciate that. Thanks, Mary Jo. Terry, how about a question from your vantage?
So the problem is I'm in that population health and the disparity and the area that we need to figure out how to be optimistic about. I do have an important question, but I want to share something because I'm really worried that COVID, as we know, is just making everything worse. This is data when we opened up our registration to 75-year-olds in a fairly affluent zip code, same denominator. We got over 2,400 people registered within 12 hours. Another zip code, same denominator, a social vulnerability index of 4, we got 400 people registered. Wow. So same opportunity, striking six-fold difference. So Bob, but I think you're right that I'm a physician. I don't want to compete with the clinician. I've practiced clinical medicine for forever. So do you have any insight into how you think we can align public health and clinical interests so that we're not perceived to be, or so that we don't compete? I mean, it seems kind of obvious that we shouldn't compete, but I agree with you. It's where we're going to end up unless we do something.
Yeah, I don't see that we're competing in a way that people in the kind of more acute care space don't recognize the need for public health. It is just more on the level of the day-to-day realities of money and politics that somebody's going to say, all right, we need another umpteen $1 billion in the public health system. We have to cut Medicare payments for hospitalizations. It's the only place that, it's going where the money is. And that the system's going to fight that. That's just a natural inclination. They will say, yes, of course, public health needs that, but take it out of the military budget. And that's not going to happen because people are going to look at the amount of money that's going to the healthcare system and say it just has to be repurposed. So there's some sort of internal competition just baked into the politics. I don't think you're going to see healthcare people either fight or even believe that it's not the right call to adequately resource public health. I just think it's going to be the way it likely plays out. The easiest way to fix it, but I'm not sure it's the best way, in fact, I'm pretty sure it's not, would be to merge the two together and in some ways put larger systems into one funding orbit. And in some ways, population health is designed to do that to some extent. You give a certain amount of money to a system and you say, system, you're responsible for all things, including keeping people healthy. and your incentive is to empty out your hospital, automatically you're going to put some of that money into public health and prevention. It may not be in the public health department per se, but it may be in all the things that, or at least some of the things that public health departments currently have to do. I think that's probably the most practical way of doing it, where you sort of force a redistribution by changing the nature of where the money goes and what the responsibility of the receiving organization is. But I don't know, what do you think?
I think it's a age-old question, and
Yeah.
I became the director of a public health department 8 months ago. I had no idea how bad it was in terms of the lack of infrastructure, the lack of data, the lack of funding. It's what I say to people, our county fund, and I love my county, but we're funded as a rounding error.
Yeah.
That's what most public health departments are funded at.
Well, I think one of the good things that will come out of the pandemic is people get that now in a way that they did not get before. The question then is what happens. Can I ask you a quick question about your 400 versus 2,200, whatever it was? Do you think that is vaccine hesitancy, or do you think that is inability to manage the systems and its complexity? You think it's more of the latter?
I think it's lack of internet access, lack of technical literacy, lack of people around to help you through it. We call it the Lexus set, seems to be getting vaccinated, and
that's, of course, I've argued for more complex, more simple distribution systems, because the more complex you make it, even in the name of equity, the more inequitable it's going to be, because who can negotiate? Just a really important point that I think we all have to emphasize. People will see numbers like that and they will assume it's vaccine hesitancy, and then there's a little bit of a reflex, which is if they don't want to get it, whatever, that's their choice. And why should we be paternalistic? It's not their choice. It is the systems do not allow them to have the same access as the Lexus set. Yeah, that's really interesting.
Well, excellent conversation and points. And I would say what gives me optimism, Bob and others, is that we have the opportunity to have this kind of conversation and relationships. So I'm fortunate to know everybody here, but there are bridging conversations that are going on now between public health and healthcare delivery that are unlike any that have happened to date, or at least in some time. And hopefully there will be momentum that we can carry forward. But Bob, folks like you that have 162,000 followers on tweet and know social media and can present those perspectives so well, we hope to stay working and in touch with you, because that interconnection is going to be so important for all of us moving forward. And boy, you've demonstrated in your career the ability to think ahead and to lead folks ahead and to articulate that, and clearly demonstrated that in the 60 minutes we've had here today. So thank you so much for taking a big landscape of topics, honing them down into a manageable conversation and presenting it so eloquently. Thank you so much.
Thank you. Thanks for having me, and thanks to everybody for all you're doing. It's really important, and I admire it. Good to see you all.
Thank you.
Okay.
Thanks,
So
Bob.
we will close today's session of Community Grand Rounds. Just a quick note that next month we are working on 2 presentations. On February the 16th, Dave Engelthaler from TGen will present on the continuing emergence of variants and the genomic epidemiology of COVID-19 in Arizona and nationally. And then hopefully working with Dr. Jackson and her colleague at Honor Health of a presentation on patient safety issues related to the pandemic. So thanks for everyone for joining. Thanks to the panelists. Thank you, Mary Jo. Please continue to wear your masks, stay safe, and we'll talk soon. Bye now.